This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2018, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist and Associate Executive Director at the AARC. I welcome you to today's presentation, Frequent versus Infrequent Monitoring of Endotracheal Tube Cuff Pressures. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. Keith Lamb. Keith is a registered respiratory therapist, adult critical care specialist, and fellow of the AARC. He is the director of ECMO at Inova Fairfax in Falls Church, Virginia, and he is the immediate past chair of the AARC Adult Acute Care Section, for which he served 2 terms. Keith has no relationships to disclose. I disclose that I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Keith, welcome to the program.
Thank you, Shauna, and I'd like to thank you and the rest of your team for asking me to present this paper, which turns out is the editor's choice for the May edition of Respiratory Care Journal. So as Shauna mentioned, the journal article is in reference to frequent versus infrequent monitoring of endotracheal tube cuff pressures. And it turns out there is sort of a paucity in the evidence in terms of this topic. A little bit of background about this topic and about this paper. You always need to sort of have in your mind what the research question is, and that's not always clear, but in this particular case it is fairly clear. And the research question is, in fact, is there a best practice related to how often you monitor pressure of an endotracheal tube cuff? So is this paper relevant? Clearly, I believe that it is. There is no current agreed upon best practice, and we'll talk a lot more in depth about that here shortly. So background, more about this background, about the background of this topic. So currently, there's no accepted standard regarding cuff pressure monitoring. I think that's obvious. I think that we'll get more into drill down into this a little bit more shortly, but there's high variability in terms of how often and in fact, and also how the procedure is taken or performed. Typically, checking a cuff pressure has been attributed to, the reason why we do it has been attributed to an attempt to prevent silent aspiration of oropharyngeal flora and to prevent tracheal ischemia and damage, and finally to prevent loss of tidal volume. So I think that it's basic science that oropharyngeal flora that's introduced to the lower respiratory tract potentially causes gram-negative infections and certainly contributes to the cost of healthcare of patients that are intubated. So it's very important. It's generally accepted across the board to keep these pressures between 20 and 30 centimeters of water. I think that the literature is fairly robust on that, and it's thought that if the cuff pressure is less than 20 centimeters of water, that you have silent aspiration of supraglottic secretions that are introduced to the lower respiratory tract. And if it's above 30 centimeters of water, then there's potential for tracheal ischemia and damage to the tracheal tissue. That being said, there are also investigations that suggest that between 20 and 30% of the time, those cuff pressures are either below or above those thresholds that we just mentioned. Also fairly common are the methods to evaluate for cuff pressure. Some folks use manometers, some folks use syringes and tubing and manometers. Some folks use minimal leak technique. However, using manometry is probably the most common accepted method. In terms of this publication, I did not personally identify any real or perceived conflicts of interest relating to the authors. So let's move into the methods that were used to produce this literature. It was a prospective clinical trial, which we know is the most desirable sort of investigation. Somewhat random in that the patients were either assigned to an odd number room in an ICU bed or to an even number room. This study was conducted in 2 large medical intensive care units at Barnes-Jewish Hospital in St. Louis, Missouri. Clearly a large facility with 1,250 bed system. Closed units, which is good because that's part of the control. Certainly could be considered part of the controlled study. They received approval for a waiver of consent by the Institutional Review Board. And these patients were investigated between October 2016 and February of 2017, so just a few months. All these patients were admitted to one of 2 of these medical intensive care units at Barnes-Jewish. So interesting way to randomize these patients. Patients that were placed in even numbered rooms were assigned to the frequent cuff pressure monitoring. And the definition of frequent cuff pressure monitoring in this case, and this study, was that everybody got their cuff pressure evaluated right after intubation. And then each of these patients that were placed in the even number rooms got their cuff pressure evaluated 3 times a day or Q8 hours, or when clinically needed. And clinical need was defined as a migration of the ET tube or tidal volume loss. So either imaging, I suppose, or audible tidal volume loss or measured tidal volume loss. Patients that were placed in the odd number rooms were assigned to the infrequent cuff monitoring, and infrequent cuff monitoring was defined as basically the same definition except minus the 3 times a day empiric check of the cuff pressure. So what were the study outcomes and objectives? Primary outcomes that were evaluated was to determine how frequently ventilator-associated events occurred. We'll define that momentarily. Secondary outcomes were 30-day and 100-day mortality rates, length of stay in the hospital, witness aspiration events, ventilator-associated pneumonia, tracheal complications, and 30-day hospital readmissions. All ventilator-associated pneumonia and ventilator-associated events were monitored by the in-house surveillance team, which turns out was the Quality Assurance and Infection Prevention Department. So these are the standard CDC definitions for a ventilator-associated event and ventilator-associated pneumonia. Ventilator-associated event is defined as a patient gets intubated. They have about 2 days of stable or decreasing daily minimum PEEP or FiO2, so decreasing support over 2 days, certainly not increasing, followed by at least 2 days of increased daily minimum PEEP or FiO2, in which the increase of that PEEP or FiO2 is greater than or equal to 3 centimeters of water or 20% of FiO2. Ventilator-associated pneumonia is a little more complex. you either have to be you have to either have a high white count or a low white count, and we know that if you have an infection, you can either have one or the other. Your system can be so overrun that you have a low white count, or you could have a high white count. The temperature is kind of the same way, either febrile or your temperature is low, so greater than 38 degrees or less than 36 degrees. And you have to have a concomitant new antimicrobial start for that indication. So you have to high white count, low white count, or high temperature or low temperature, and a new start of an antibiotic for that specific indication. Additionally, subjects assessed as having a VAP have to also meet criteria in Table 1. So Table 1, you have two different criteria lists. The first one is you have purulent respiratory secretions with at least one or more specimen collections plus one of the following positive cultures. So you have to have a positive culture in endotracheal aspirate, BAL, lung tissue, or protected brush, or without purulent secretions. And criteria 2, you have positive pleural fluid, positive lung histo, positive diagnostic test for Legionella, or positive diagnostic test for respiratory secretions for influenza virus, so viral respiratory RSV, adenovirus, parainfluenza virus, rhinovirus, etc. So, definition of a VAP is a little more complex. Statistics. So the authors actually performed a power analysis, and a power analysis is kind of how you figure out whether or not, or figure out how many subjects or patients you need in your study to be significant. And in this case, they decided that, and sometimes this is kind of one of the ways of doing this is just kind of looking at other studies to see how many patients they had in their study, something similar, and to see what, if they had statistical significance, and if they did, then that's kind of a good starting point. So what they did with this power analysis is decide that what they needed was a total of 292 total patients with 146 in each group, since there were two groups. And if they did that, that would demonstrate a non-inferiority between the two groups, meaning that their new way of doing it was not worse than the old way of doing it. In this case, there is no consensus on how to do it, but they wanted to prove that checking cuff pressures less frequently was not worse than doing it more frequently. The rest of the statistics are fairly straightforward. Typical t-test to analyze normally distributed continuous variables, Mann-Whitney. Categorical data were reported as frequency distributions and analyzed using chi-square test. Finally, a Kaplan-Meier curve used to look at survival data between the two groups, and then as fairly standard, p-values of less than 0.05 were considered statistically significant, and all of these were reported. Tests were done two-tailed. So results. They screened 322 patients. They excluded 17 patients. 16 of those had been intubated prior to study inclusion, and one was moved from an even number room to an odd number room. They wound up with 305 patients, which was more than what they felt like they needed to be significant. They overshot the patient number in the frequent cuff pressure monitoring and undershot by a little bit the infrequent cuff pressure monitoring group. So fairly evenly distributed. So interesting results. 54% were assigned to frequent cuff pressure monitoring. And remember, that was you get your cuff pressure checked once you get intubated. You get it if there's clinical need, loss of tidal volume, or change in imaging, that looked like the ET tube had moved, etc. And then 44.6% or 45% were assigned to the infrequent cuff pressure, which was the same as the frequent minus the empiric 3 times a day cuff pressure check. So total numbers of cuff pressure checks for these groups were 1,531 for the frequent and 336 for the infrequent, which that's a 5-fold increase or 5-fold number in terms of the one group versus the other. So their primary outcome was ventilator-associated events. Very infrequent for both groups, but similar, 3.6 or almost 4% versus 6%. Statistically not significant. Witness aspiration events, 0.6% versus 0%, also not significant. And ventilator-associated pneumonia is 0% versus 0.7%, also not significant. So in terms of those, the primary outcomes and some of those secondary outcomes, not significant. "30-day mortality, 31% versus 30%, again, no difference at all. Median length of hospital stay, 10 days versus 11 days, not significant. And probably the most interesting finding is that the 30-day hospital readmission rate for these folks was less for the group receiving infrequent endotracheal tube cuff pressure monitoring. So in this case, if you check the cuff pressure 5 times more often in the one group than the other, the frequently checked folks had almost twice the readmission rate as the infrequently checked patients. Kaplan-Meier curves were comparing survival, showed no difference for subjects in the frequent monitoring group compared to the infrequent monitoring group. So everything that we've talked about so far, excuse me, in terms of results, has been statistically insignificant except for the 30-day readmission rate. Here's the Kaplan-Meier curve that basically sit on top of each other here, showing no difference in mortality. So baseline characteristics, demographics, severity of illness, race, etc. Nothing that's really significant in any of these data. Fairly evenly matched. The outcomes, again, I don't want to repeat everything that we just talked about, but it is interesting to see if you look at the p-values on all of these outcomes that almost all of them are statistically insignificant. Of course, endotracheal tube cuff pressure assessments are going to be significant because they're controlled by protocol. However, the only other one that is significant, again, is the 30-day readmission rate, with the folks that had multiple frequent cuff pressure evaluations being more commonly readmitted to the hospital. So, in discussion here about things that we've talked about so far. 5 times more frequent cuff pressure checks in the frequent monitoring group were not associated with any clinical advantage. I think that's fairly straightforward here. There was no clinical advantage to checking the cuff pressure more often. Rates of ventilator-associated events and ventilator-associated pneumonia were low and similar in both groups. ICU and hospital stay were very similar. There was a significant difference in the rate of 30-day readmissions. The authors in the body of the paper mentioned a paper that was done in Australia that reported that there was a survey that asked 29 different centers how they monitored cuff pressures. 28 out of those 29 routinely monitored cuff pressures, but the targeted pressures were highly variable. In other words, they weren't in the range necessarily of what we have established in the literature as being safe. As a matter of fact, the low range was 10 centimeters of water, and the high range was 30. So the low range was certainly different. And there's very high variability in terms of how they measure cuff pressures as well. So even outside the United States and Australia, big difference, big ranges in cuff pressure targets, and big difference in the methodology they use. Now, anybody who's been an RT or practiced in critical care for a while are probably aware of the literature in terms of changing disposables, changing circuits, changing HMEs, changing suction catheters, etc. And it's been fairly well established now for quite some time that those things didn't need to be. There was no clinical advantage of changing those things on a routine basis, especially with high frequency in terms of clinical outcomes, particularly nosocomial infections. Other clinical studies have found that more frequent manipulation of the ventilator circuit or its components can result in more frequent complications, including aspiration events and pneumonia. So that goes kind of hand in hand with the first couple of bullet points there. Things have changed also in the last few years. Various modifications of the ET2 design itself have occurred. They prevent biofilms on the tube surface, obstruction, aspiration events. So, other things have been improved upon over the last few years before now. With all of this evidence that less frequent manipulation of the ventilator circuit, et cetera, is safe and is potentially less injurious to the patient, it certainly seems logical to extend this observation to the assessment of cuff pressure monitoring frequency. Now, this is a statement or a discussion point that the authors made, and the question that they came up with is: more frequent monitoring of cuff pressure is a waste of time and/or injurious? It's a good question, isn't it? So far up until this point in the paper, their question was: is there a best practice? Does it make a difference how often that you check the cuff pressure? And in terms of everything except for 30-day readmissions, it sure seems as if that's the case, and that it probably doesn't make a difference clinically. Now, that all being said, they admit to some study limitations, and all studies have limitations. You can't get rid of all of them, but so the study limitations that the authors sort of expanded on, one of them, the first one is that they didn't really accurately document the absolute values of cuff pressure measurements. So, I mean, that seems like kind of a if you're trying to establish best practice for what a cuff pressure should be, which would be the reason that you're checking the cuff pressure, then it would stand to reason that that's an important point. Another one is if one of the reasons why you sort of monitor cuff pressures and you try to keep them above 20 and below 30, which is the standard, one of the reasons why you do that is to decrease the opportunity or mitigate the opportunity for laryngeal or tracheal injury. They also didn't do that, and admittedly that's not always easy to do because that would require some sort of bronchoscopy in order to evaluate that. So if you extubate people over a bronchoscope, then that's one way to do it, but that's probably not their standard, and nobody else's standard that I know of. Room assignments, I mean, if you know all one sort of patients going into the odd number rooms, and you know the other ones are going to the even number rooms, and you have two groups, then there's certainly opportunity for bias, unblinded assessments of the primary outcome. So that's probably also not the best way to do that. But it's a way to do it, right? It's you know, randomization's not super easy to do. So another really good point, I think, is that the study was only carried out in medicine patients. So we know that medicine patients probably are not the category of patients that have the highest incidence of ventilator-associated pneumonia or events. Certainly the neurosurgical patients and trauma patients may have a higher incidence of that. So if you were to evaluate those patients too, would you sort of get the same results? And also the bone marrow patients that are obviously immunocompromised. So you may, if you did the same study amongst several different sorts of ICUs, then your results might be different. So that's a limitation as well. Another interesting one is that, geez, they really had really small numbers of VAEs and VAPs. We're not benchmarking their data with anybody else's, but it's sure from the outset sounds like those numbers are very low. 0% is a low number. Finally, there could be some ascertainment bias by the department that was monitoring for VAP and VAE. However, they would have had the same bias amongst both groups, so it probably wouldn't have affected the comparative results, overall results maybe, but not the comparative results between the two groups. So soon after the paper was published, the editorial was published, and you know, editorials are always good to kind of illuminate other limitations or other ideas, and are very useful to use to compare to the original paper, and also to recommend potential improvements or further investigations. So the editorial authors go through and kind of look at all of the key details that were covered in the original paper. And so they go back and they kind of expand on the historical data and the historical ways of taking care of these patients and what has changed. And so, you know, those of us who have been doing this for a while remember when we used to change the HMEs, the suction catheters, you know, all of the disposable things on a regular basis. And then, you know, people started saying, well, geez, do we really need to do this? And so there were a bunch of studies that looked at those things. And if you fast forward to today, there's clearly been a paradigm shift where now less is more, and patients are gently supported in an attempt to kind of mitigate iatrogenic injury and unnecessary costs. Now, this is applicable to everything that's done in critical care, right? It's not just the HMEs and suction catheters. It's the ventilator management. It's everything. And so this less or more paradigm shift is certainly taken hold across the spectrum of all ICU patients. They also talked about how the literature has not shown a difference in VAP when disposables are changed weekly instead of daily. So that's that's kind of the same thing that I was just talking about. But there's certainly a great savings of money and no change in all of these secondary outcomes that we've talked about. So, you know, when you want to change a standard practice, no matter what it is, it's incumbent upon the person who wants to change the standard of practice to verify that either outcomes are better or there is less money being spent, right? So those are the two things that administrators, people that write checks, really want to hear. And especially the money part, right? So if you go to somebody and you say, I want to do this, you have to prove that, hey, this is not worse, it's not inferior, or it saves money. So it's been the paradigm now for quite some time to do these things less frequently and to a great cost savings. Kind of at the same time, ET tube designs have been changed that have reduced the incidence of VAP. Subglottic suctioning, certainly in a certain, maybe not in everybody, but in certain patient populations, those patients that are more likely to develop ventilator-associated pneumonias, sort of like the neurosurgery patients I just talked about, the trauma patients that have TBIs. They're at a higher risk for VAP. So anyway, these newer ET tubes have demonstrated that lower VAPs in some subsegments of critical care patients. However, cuffs made of innovative materials hasn't really panned out, but maybe the ones that have been lined with silver coating and, again, have the subglottic suctioning access ports have. So we can't forget about the literature that's already been reported and has substantiated some of these things. There have been reports of an increased incidence of VAP related to ET tube cuff pressures, and those have been related to cuff pressures that are less than 20, so that's sort of established. There are also reports that demonstrate that use of cuff pressures above 30 may reduce blood flow to the trachea and cause ischemic injury. That's been established. The editorial authors here were concerned about the primary outcome that was used. In this case, the primary outcome was ventilator-associated events. And I don't want to go way back to the beginning where we talked about that, but ventilator-associated event is a stable period of time on the ventilator with either stable or reduced support levels via PEEP and FiO2, followed by a sudden sort of increase in support levels, FiO2 and PEEP. And there are other things besides ventilator-associated pneumonia that trigger a ventilator-associated event. So the editorial authors were concerned about using the ventilator-associated events as the primary outcome. Some of those things are atelectasis, pulmonary edema, ARDS, etc., but not necessarily pneumonia, infectious pneumonia. So concerns with using VAP as secondary outcome because VAP is most likely is the most likely sequela of inadequate cuff inflation and aspiration of oral flora gram-negative bacteria, right? So maybe it would have made sense. Again, this is just spitballing, and this is a discussion. But maybe it would have made more sense to use ventilator-associated pneumonia as sort of a primary outcome when you're talking about evaluating cuff pressures. Ventilator-associated events were never intended to be used as a surrogate for VAP. Editorial authors pointed that out, and that's true. Reports that clinical VAP may occur in only 30% of ventilator-associated event cases, which kind of substantiates what we just talked about a minute ago. That being said, it's possible that many VAPs were overlooked, which reduced the reliability of the chosen measure of effect. So if you're overlooking one of your big secondary outcomes, then that's not effective either. And again, you know, they did a power analysis, certainly, and seem to have achieved that. But that's a kind of an you know, it's not terribly sensitive in terms of translating into every study. So the low rates may be a result of underpowered study and detecting differences between these two groups. So if you have, you know, you have a number of patients, you have an adequate number of patients, but you don't have an adequate number of your primary and important secondary outcomes. Another good point that these folks made was that all ET tubes are not created equal. You know, they don't all. I mean, we've seen reps come in and show us different ET tubes, and you know how much one is more likely to have secretions drip down around the cuff. So they're definitely not equally created. So the results that the authors gained here may be true regarding the specific endotracheal tube that they used, but the same results may not apply if you use something different. The editorialist also went on to say that, you know, and this makes sense, that there may be two causes of the negative finding of this trial. And that is that, you know, one of them is that the ET tube that they used was just a really good ET tube and maybe superior to other endotracheal tubes, and so those tubes held pressure more effectively and prevented leakage. Or, and I think this is probably more likely, in my opinion, there's so many other things that have been addressed to address iatrogenic infection, that these bundles, you know, that we use so commonly now have actually offset the risk of VAP associated with cuff pressure inconsistency. So maybe way back a long time ago, it was more important that your cuff pressures were within a specific range, but now maybe that we have these bundles that significantly impact the number of ventilator-associated pneumonias that occur, then maybe those cuff pressures aren't as important. I don't know, but you know, that's a question that needs to be answered. These folks did not look for evaluation or evaluate possible tracheal lesions associated with hyperinflation of the ET tube cuff. Again, like I said a few minutes ago, you know, so I don't think that it's standard to evaluate for that. Maybe if you're studying cuff pressures, then it might make sense to make that exception and go ahead and evaluate for these lesions that may occur with high cuff pressures. There are reports that these lesions, folks that do use bronchoscopy and evaluate for these. I know that when I used to be very involved in bedside percutaneous tracheostomies, we would see these lesions as we were pulling the ET tube out to place the percutaneous trach. And I don't know what percentage of patients that occurs in, but it certainly does. And there have been reports, obviously, which is why we use 30 as a cutoff point, that if you use 30, then you're more likely to develop a lesion. And I think that there are many other things that are associated with that as well that aren't reported here, but nutritional status certainly, and volume status, et cetera. So it seems to be reasonable that maybe if this data is expanded on and somebody else does it at a different center, or if there are multiple centers involved, that we might be able to find a better answer. There is data, recent data, that continuous versus sporadic cuff pressure monitoring leads to fewer hypoinflations and lower incidence of VAP. There is, and it's fairly convincing. So, you know, that has to be taken into consideration too. And the question should be asked that, you know, is continuous monitoring almost like no monitoring? In other words, if it's a person that's checking the cuff pressure, there are certainly, and you've probably all seen it at the bedside, there's a certain amount of pressure that's lost when you try to check for cuff pressures. And so maybe continuous monitoring is simply taking out the human element and actually when it's manually done and losing pressure for a short period of time that allows for secretions to be introduced in the lower respiratory tract. ET tubes lose pressure. Anybody who's ever gone and checked them on a regular basis knows that they're not always the same as they were before when you went to go check them. There's certainly mechanical reasons for that, most likely, et cetera. I don't think that it's well understood, and maybe understanding that first would be a good direction to point yourself. So away from the editorialist and back to the original authors, they conclude that infrequent monitoring, and based on their data, this is true if you believe in their data. Infrequent monitoring of cuff pressures is likely safe compared to more frequent monitoring. It's also true that hospitals perform frequent routine monitoring of cuff pressures despite the absence of audible leak or loss of tidal volume. So there are certainly places out there that go in every 4 hours and check that cuff pressure like clockwork. And so, you know, this paper, this data supports that maybe that's not necessary. They go on to say that in the future, if other studies can be confirmed by other centers, then maybe if enough of this data is accumulated, then people might be impressed and may, in fact, want to change their practice standards. They also go on to say that they feel like the era of performing frequent routine assessments of cuff pressures may be coming to an end, as been suggested for the assessment of frequent gastric residual volumes, et cetera, because of a lack of observed clinical benefit. And my response to that particular part of their conclusion is that it needs to be qualified. It needs to be qualified by additional investigation as it relates to endotracheal tube cuff monitoring. So that's the conclusion. I want to just make a couple other little observations here before we open up for questions and answers. Just kind of a reminder about this study. This is a study that should have been done, needed to be done, and it has contributed useful information about this topic for sure. I think that somebody should pick the ball up and run with it. They should expand on this data. It's a good start. You know, this was a single center study, which kind of takes some of the oomph out of it. There are some study limitations that were not insignificant, certainly. Maybe they should, somebody should use VAP as a primary outcomes measurement instead of ventilator-associated events. I don't know. I mean, some smart people need to sit down and think about this. You cannot ignore the fact that there's recent literature that suggests that continuous cuff pressure monitoring has reduced VAP in certain patient populations. So maybe it's the method of monitoring and not the frequency. again, continuous cuff pressure monitoring might really be the ultimate in not monitoring it often, because you've taken the human manipulation of the airway out of the equation. And that's it.
Thank you so much, Keith. We have quite a few questions. So what I'm going to do is go back to this table so that we can kind of keep this in mind as we go through a couple of our questions. So bear with me for a second. It's been a little while since I've been in clinical practice, but the point of our endotracheal tube cuffs is to obviously help protect the airway. And as I was reading the article and listening to how you were explaining things, there were a couple of fairly big impact factors that I was thinking. Obviously, we have to balance between too much pressure in the cuff that would damage the airway, and if you are overly ambitious, actually cut off some blood flow upon occasion. But at the other hand, we don't want anything to slip past that cuff. So once we've intubated the patient and we have established a cuff pressure that's in that zone, whatever we've identified as appropriate for that patient, what is the rationale behind even checking it at all? Why would we even want to manipulate that cuff once we get it into a place that is acceptable?
Yeah, so start out with a really hard one. I think that, and I know to some extent, that those pressures change throughout the day. There's and some of the pressure changes are related to actual leak of volume out of the cuff. We don't know how often that happens. We don't know how much it happens or how much volume comes out. Volume status, edema of the trachea changes the pressures. Edema of the trachea changes the threshold at which the pressure might or might not be injurious to the patient. So if you got low volume status, then the impact of that pressure on the perfusion of the trachea would be different than if you had high volume status, for instance. So I think the rationale for keeping it where you find the pressure and you want to keep it there, the rationale for checking it has always been that it changes, and it's kind of like I like to use crop circles as an example in rounds whenever it's applicable. I know that it happens. I've seen it, but I can't explain it, and so I think that's always been the rationale in my mind, at least in my clinical practice, why I'm interested in checking the pressure.
That makes complete sense. So now we have to balance checking that cuff and ensuring that that pressure stays in the right space, while also taking a risk that we are releasing some of that pressure, right, whenever we do the manometer check, and then maybe even a potential of damaging the pilot balloon, yeah?
Right. Yep. Because the more often you, I think that the more often that you manipulate that valve in the pilot balloon, the more likely it is that thing becomes less intact, I'll say.
And then we've also had issues, of course, where we've damaged the line between the pilot balloon and the cuff, and that's when we break out those handy-dandy little kits to
right.
thread a needle into the line, right, and with a stopcock, yeah.
Yep.
So a couple of our viewers have mentioned that they use a specific ventilator that can measure automatically when you hook it up the pressure in the cuff. So a line that comes from the ventilator that automatically does those things. Would such a system like that be, obviously it would be beneficial for gathering data, would that be more, provide a more consistent experience with the cuff versus checking, Q4, Q12 or whatever with a manometer or with the minimal leak techniques?
Yeah, I think so. I've not got experience in using those devices, but I think that it makes sense. I think the science is there. I think that probably, again, I think the human factor, when you go in to check the cuff pressure, you always run the risk of deflating the cuff to some extent and introducing, secretions that are sitting above the cuff as they drip down around the sides of the cuff. And I think that's always a risk. I don't know if there's a perfect method to doing that, but I think that if you are continuously, it stands to reason to me that if you are continuously measuring the pressure and you're not manipulating the cuff, the volume in the cuff, while you do that, it's just you're just transducing the pressure to a monitor. That it stands to reason to me that you have mitigated some of the risk that's involved in checking the pressure manually, and that might be why there's some data that supports the use of continuous monitoring versus intermittent monitoring for that reason.
So you mentioned something that brings up another question. With this particular study, did they make any mention about whether or not they suctioned the space above the endotracheal tube cuff prior to those the cuff checks?
I don't believe they did mention that. That's a good point, though. I'm not sure. I don't think they did. I didn't see it if they did.
And then one of the other issues that I was thinking about with the study, and this brings me back to the slide that we landed on here, the table 3, you pointed out that the 30-day readmission was really the only significant difference here. But looking at the duration of mechanical ventilation between the two groups, about 3 or 4 days on average. So we really didn't have really long-term patients within this study. Is there any way we can extrapolate the information that they provided us here in this survey to patients with tracheostomy tubes who require their cuff inflated?
Yeah, so it seems like a sort of a low ventilation day number for a medicine ICU, doesn't it? Yeah, so Shauna, can you just kind of reiterate the question about the tracheostomy?
Sure. So some of our patients are only intubated for a few days because they get, a quick tracheostomy, because we know that they're going to be on the ventilator for quite some time.
Yep.
And as we're looking at the frequent versus infrequent cuff pressure, if I've got a tracheostomy patient, fresh trach, or maybe even somebody who's been trach for a couple of weeks, or a patient who's had a tracheostomy tube for some time and has recently come to the hospital for some reason, is there enough information here for me to say, yeah, I can use what these people found when I am also caring for my patients with the tracheostomy tube with the cuff inflated?
Yeah, I don't think that you can. I think the problem with trying to extrapolate this and use it in a different, so that the tracheostomy, so anybody that was trached was excluded from the study. I think that if you have an intact glottis, that's a different kind of patient, and I don't think that you could apply this data to them. So we're not even sure if you could apply this data to anybody. but there's certainly a strong suggestion that you can apply it to intubated patients, but I don't think that you could to trach patients.
And that brings me to the last question that I'll ask of you today. If I'm working in an adult ICU and I'm listening to this webcast and I'm reading this article and I'm getting kind of excited, right? Because I'm always worried about how frequent we test our cuffs. Should I get all excited and go back to my manager today and say, here's a study, we really need to change our policy? Is this data strong enough for us to change our clinical practice?
Yeah, so that's always the question. Everybody wants to try to do that. I don't think that I would change my practice based on this study. What the study would, as a bedside clinician, what the study would suggest to me is that I need to take care. I need to be careful when I do check cuff pressures. And in terms of overall strength of the study, I think that that somebody needs to take this. Expand on it, do a multi-center evaluation before I'd be prepared to run to my manager and recommend changes.
Thank you so much, Keith. This was a really great review of this article, and I think a really important piece of information for us to have as we go forward, but also some really good questions for hopefully some researchers out there who want to also add to the literature base. So thank you for hanging with us today.
Oh, you're welcome. Thanks for having me.
And thanks to everyone who joined us today. The AARC kicks off the Summer Chronic Pulmonary Disease Series on Tuesday, May 29th, with the role of the respiratory therapist in cystic fibrosis with Dabney Idson. And then the next webcast in the series is on Tuesday, June 12th, with respiratory care in pulmonary hypertension with Dr. Bob Walter. Thank you again for joining us, and have a great day.
Okay, everyone, that is all the time we have for you. Thank you, Keith, for sharing your expertise with us all, and thank you to all of our attendees for your interesting questions. In just a moment, you will see a Submit Credit button on your screen. If you are an individual who has registered for this program, excuse me, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This does conclude today's presentation. To end, simply X out of your browser window. We hope you have a great afternoon.